So topics in adult spinal deformity is something that I'll be talking about because this is something that took me the longest time to understand as a resident. Well, because part of the reason is that, when you first open up the textbook of Benzel, this is something that you see: sacral soul, pelvic tilt, pelvic incidence. It's not something that we talked about a lot during the residency, and it can be quite overwhelming, right? Looking at the bottom pictures, there's not enough spaces to measure more stuff in there. And it's also a very difficult concept for me to apply when you start measuring all these angles and such, because looking at my training at Level 1 Trauma Center, we did fair share of pretty much all the traumas in degen, but when it came to lumbar pelvic fixation and deformity, I really feel like I can probably hand count those few cases that we've done. So therefore, hence my fellowship here, which Dr. Zhang gave me a great experience so far. So training makes a difference, not just for me. It turns out in 2014, it's really about the time then when I began my training, when they put out a survey for double ANS members of a questionnaire of spinal deformity knowledge consisting of 5 different categories, including radio, spinal, pelvic parameters, quality of life, surgical indication, and techniques. Surgeons who completed a spinal fellowship consistently scored higher, as you see here. And when the surgeons identify themselves as experts deformity surgeon, they had the most right answers. And these questions were consisted of 10 questions and were put together by so-called experts of the field. And question 8 here is the question that had the least amount of correct answers by the surgeons. The question reads: a full correction of patient thoracolumbar curve is most likely result in. The correct answer here is coronal imbalance. What the experts were going for here is that if you don't recognize it, the fractional curve on the bottom of the spine, is that you will be throwing off that curve and worsen the coronal imbalance. If you look at question 6 here, in this patient referred for 2-level degen disease and low back pain, best strategy would be in situ fusion, 2-level instrumented fusion, TLIF, osteotomy. And although fusions are, I think, could be a viable answers here, what they're going for is that you need to recognize the sagittal imbalance measured from C7 plumb line drawn straight down and measure that distance to the sacrum. And the only way to correct that of these options is osteotomy. So here is my very rudimentary understanding of deformity. First, to distinguish AIS, adolescent idiopathic scoliosis, versus adult degenerative deformity, is that scoliosis is only a part of a deformity. During my training, I was fortunate enough to work with pediatric deformity surgeons, and this is kind of the surgery that they do all day long, is a lanky type 1 type of thoracic deformity, which consists of 50 to 60% of pediatric deformity. So the surgery will go anywhere from upper thoracic to upper lumbar spine. And these curves tends to be very flexible unless they have neuromuscular scoliosis. Whereas on the right here is the types of adult degen kind of deformity. On the top left is de novo type adult degen scoliosis or deformity. top right is the untreated AIS, bottom left is iatrogenic, and on the right is hyperkyphotic deformity. And you may see the theme here, other than maybe the untreated AIS, is that adult deformity tend to involve the lower part of the spine, which makes sense because all the weight kind of translates to the bottom of the spine. So looking at the common and procedures performed, that's for me how I think about the difference between AIS versus adult degenerative surgeries is thoracic versus lower lumbar and lumbar sacral. Another key difference is AIS is driven by the radiographic risk of progression, whereas in adult degenerative surgeries, this surgical treatment is assessed by the pain and disability of the patients. And turns out these patients are quite disabled. In 2004, there was an international quality of life survey that was conducted in 8 industrialized countries. And they wanted to identify the key illnesses that had the highest impact on their quality of life. And what came out to be the top was arthritis, congestive heart failure, chronic lung disease, and diabetes. About 10 years later, they wanted to compare the spinal deformity to those adult chronic illnesses. And you can see how those patients with adult spinal deformity performed or scored a lot lower in short form survey. Here, this is blue is the surgical candidates, and these are non-op patients with spinal deformity. So why are these patients disabled? In 1970, the French spine surgeon Jean Dubois coined the term cone of economy and drew this very famous picture that turns out we're supposed to stand up straight, and any deviation away from that, any leaning forward or back, puts us in a very disadvantage, therefore increasing the energy expenditure and the disability. The way I like to think of this in kind of as an extreme example is Roman chair exercise. I would challenge anyone in the room that if you try to do this exercise more than 10 or 20 reps, it is really the most miserable exercise that you can do at a gym, because you have really taken out the cone of economy and put yourself in the through that's fighting against the gravity. So this is one of the landmark papers highlighting the importance of sagittal balance, that cone of economy. When they looked at 750 patients with adult spinal deformity, multi-center retrospective review, and looked at their sagittal balance measured by C7 plumb line back to the end of the sacrum. What they found out was that as you deviate away, as your sagittal imbalance worsens, your quality of life, disability worsens. And what was particularly interesting about this paper was that the area of greatest kyphosis really contributes to your disability, especially in lumbar spine. Unfortunately for us is that life is a kyphosing event. As we age, we become hyperkyphotic in thoracic spine, and we lose that lumbar lordosis and become more flat in lower back, and we flex our hip, therefore becoming even more flat, and we hyperlordose our cervical spine to maintain that horizontal gaze. And that's where this pelvic parameter comes in. If we say that lumbar lordosis play such an important role in sagittal imbalance, we need a way to measure a given idea where that number should be, and that's where pelvic pelvic incidence come in. Pelvic incidence is measured by midpoint of the head of the femur or acetabulum to the midpoint of the sacral end plate, and a line drawn perpendicularly from that end plate. Pelvic tilt is a line drawn from midpoint of the sacrum and line drawn straight up, and it's an angle. And sacral slope is the angle of the sacrum, which is fairly straightforward here. And adding pelvic tilt and sacral slope will give you pelvic incidence. I put this picture up here because it took me a very long time to understand why pelvic incidence is a fixed parameter, whereas pelvic tilt and sacral slope changes. If I had drawn a line from acetabulum to midpoint of the sacrum, from here to there, that line or the distance cannot change unless you have a significant amount of pelvic fracture, and you're simply drawing a perpendicular line from that, so that angle cannot change, whereas pelvic tilt and sacral slope will change based on where position of your pelvis. To me, this two diagram or the pictures was the easiest picture to understand the concept. For example, everyone in this conference sitting down, what you have done is rock your pelvis back. What you did was retrovert your pelvis. The result of that is straightening of your lower lumbar spine, therefore eliminating lumbar lordosis, decreasing sacral slope, and increasing the pelvic tilt. And as you stand up, what you do is you antevert the pelvis, rocking the pelvis forward, reintroducing lumbar lordosis, increasing that sacral slope, and decreasing the pelvic tilt. So looking at the general population, we estimate that lumbar lordosis should lay somewhere plus minus 10 degrees of pelvic incidence. And in pathological state, there will be a mismatch of that pelvic incidence and lumbar lordosis. And mean pelvic incidence in population is 50 degrees, although that really doesn't mean anything. Pelvic incidence is an inherent measurement for individual, and degree of pelvic incidence really doesn't tell you whether you're in a pathological state or not. Here's an example of a person with a large pelvic incidence. If you look at Donald Trump standing, he's got a very large pelvic incidence. He's got a horizontal sacrum. Your sacrum is basically laying forward. Therefore, you have a very large sacral slope and long and high lordosis, whereas Joe Biden has almost straight up sacrum, small sacral slope, and lower short lordosis. So two different pelvic incident doesn't really mean much as to whether they're in disabling pain or not. That's just inherent mechanism or the numbers that they have. So how about pelvic tilt? Pelvic tilt tells you how much is really the number of compensatory mechanism. What I mean by that is if you look at this diagram of the spine on the left, this patient has a very large, spine has a very large SVA without any pelvic tilt. Remember, the measurement of pelvic tilt is from the line drawn from the midpoint of the sacrum down to the head of the femur. And patients can compensate for that SVA by rocking their pelvis back, therefore increasing the pelvic tilt. And as you rock your pelvis back even more, then your spine becomes more sagitally balanced. Here's an example of what happens as we age. Here's a 34-year-old woman with spinal imaging. What we're looking at is fairly balanced spine with a low pelvic tilt. And as we age, This patient has rocked their her pelvis back to remain sagittorally balanced. And finally, in this 80-year-old woman, this patient has really retroverted the pelvis as far back as she can, and bending her neck backward to maximize cervical lordosis to maintain the horizontal gaze. And as she decompensates or exhausts this compensatory mechanism, she is bending her knee to, again, maintain that horizontal gaze. So this is a paper highlighting the importance of pelvic tilt. They looked at 125 patients who qualified for deformity, and looked at their ODI and health form questionnaires. What they found out was that pelvic incident and lumbar lordosis mismatch was a leading cause of pain and disability, whereas sagittal imbalance was most disabling when it came to standing disability, but pelvic tilt had the strongest correlation with walking ODI. If you look at this picture here, this person is doing a wall sit exercise. What he's doing is really flattening his lower back and really rocking the pelvis back to maximize the pelvic tilt. And you can, and I'm sure everybody has tried this and know how miserable this experience is. Whereas when you're sitting like this, you have the chair supporting you, but without the chair, you're really using your hip and your quads and hamstring to maintain in this position, which makes sense and correlates with this study. So studies have found and have given us the alignment objective for SVA, pelvic tilt, and lumbar lordosis and pelvic incidence parameters, where I like to think of it as simply is just 5 centimeters and 10 for pelvic incident and lumbar lordosis, and 20. So 5, 10, and 20. It's just easier for me to remember that way. And planning is key. When they looked at 8 centers with really well-known deformity surgeons, and what they did was look at the preoperative and postoperative measurement of SVA alignment, and they categorized these outcome success and failure based on how much, whether they were able to correct SVA to within 5 centimeters versus 10, which they categorize into failures. And there are a few that laid in between, and those patients were excluded from the study. And what was particularly interesting about this study was that if you look at pre and post surgery, so gray bar is the failure and white is the success. And this diagram is measurement of SVA pre and post, and this one is lumbar lordosis pre and post. What's striking here is that the degree of correction of SVA is about the same for both success and failures. Same thing with lumbar lordosis. So what this is telling us is that even the hands of expert deformity surgeons, they were really, in 2012 and prior, they were really doing kind of the same thing, same type of surgery, PSOs, whatnot, and failed to recognize and was not correcting or undercorrecting these patients. And here is an example. Not really, this paper is not from this radiograph is not from the study, but you don't have to be a spine surgeon to know that this patient after surgery remains undercorrected. Another important thing about planning is you want to have a good imaging. And I put this in here because I do think that EOS is better than conventional spinal imaging. EOS is here's a result of EOS imaging. It will give you both lateral and AP view and also give you a 3D view, but this exposes a lot less of a radiation to the patients than conventional X-ray, and hence really preferred by the pediatric deformity surgeons. And why I say this is better is that if you look at this picture on the left, this patient looks fairly well balanced, but if you look on the picture on the right, this patient is bending the knee to maintain the horizontal gaze and stand more straight. So how can we make this measurement and use the numbers? I like to use this software called SurgeMap. Thanks to Dr. Zhang, all the trainees now should have access to this, actually the upgraded version. Initially, a few years back, you had to download this on your desktop, but that is no longer required. All you have to do is to go to the surgemap.com and just sign in. And I wanted to go over this with you because this is very convenient software, and it took me quite a while to figure out, and I want to help trainees kind of figure this out. So first screen that you would go to is to import your X-ray, and you can use a screenshot or upload the JPEG or whatnot, but what I like to do is just snip the screenshot, because then you don't have to worry about including the patient identifiers. And then you click the patient and you open this imaging, and this is something you see. What I like to do is calibrate first, and every X-ray should have this bar which tells you how many centimeters or inches, and you can assign that calibration so that it can give you an accurate measurement. So first thing you do is click that SP shape, and you want to draw the head of the femur. And after that is pretty straightforward. You put a line at S1 end plate, and then L1 end plate, and then T1 and C2. Just by doing that, it has given you lumbar lordosis pelvic incidence mismatch or match, and also give you a pelvic tilt as well. And because we have calibrated this X-ray, you can also measure the SVA, and in this particular patient, stature imbalance or SVA measured 13 centimeters, pelvic tilt of 19, pelvic incident lumbar lordosis mismatch of 39 degrees. So you can plan for surgery this way. You can first plan for wedge osteotomy if you're a 3-column osteotomy type of surgeon, and do a PSO. In this particular scenario, I planned for L3 for PSO. And here is what you can plan for is we went from pelvic incident lumbar lordosis difference of 39 degrees to 10 degrees, and improvement of SVA from 113 centimeters to 7 centimeters. And if you're more of a lateral or ALIF or TLIF type of surgeon, and you can also plan for that instead of planning for osteotomy, you can design your interbodies and plan for correction of lumbar lordosis that way. And this is the result of actually what the surgeons did. What the surgeons did was 2-level ALIF followed by multi-level lateral surgeries, followed by percutaneous placement of the screws and rods. And you can see the degree of correction here. What's also very cool about this, Dr. Anu Amin have shown me this, is that once you have calibrated this image, you can actually plan for your rod, which frequently is one of the most challenging aspects of deformity surgery. But you can, because you have calibrated the imaging, you can bend these rods in your office with a rod bender and autoclave it, and then who is my former chairman. And his question was, "Are you sure?" Because his argument was that these deformity patients don't do quite well, and they are oftentimes miserable, and this makes the surgery miserable for us surgeons. And he's certainly not 100% wrong. And this is a surgery that I was involved with 3 different times in Mississippi. This patient had a previous thoracic fusion and a corpectomy by an outside surgeon, and came to us with a severe kyphosis at thoracolumbar junction. And no matter what we did, how many metals of cobalt chrome we threw at her, she kept breaking. And this is kind of the last construct that we did before I left Mississippi. Looking at the traditional or more historic numbers of complication of deformity surgery, Dr. Harke was certainly right. The overall complication rate was 80% in these adult deformity surgery, major complication of 30%, and minor complication of 60% in this paper. And reoperation rate risk at 4 years was 48% in 2012 paper. Because there were so many different classification and identifiers of this complications, ISS, International Spine Study Group, wanted to standardize classification system for complication following adult spinal deformity. It differently grouped into intra-op, perioperative, and post-op, and they also subgrouped them to major and minor complications. When they looked at these complications, the 4 different categories were responsible for almost 70% of major complications. Implant failures, namely rod fractures, radiographic, PJK, proximal junctional kyphosis, and proximal junctional failures, infections, and operative blood loss. And this is a paper looking at specifically at rod fracture risk after a patient undergoing spinal deformity surgery. Rod fracture was associated with PSO in 1/4 of the cases, and material chrome rod, cobalt chrome rods, smaller diameter had a bigger chance of rod fracture risk, older age, greater SVA, malalignment, pelvic incidence, lumbar lordosis mismatch, and greater correction after surgery. So the experts are coming out with different ways to prevent these rod fractures. And these 2 particular methods, I think, is gaining attention: satellite rods at the site of 3-column osteotomies or PSOs, and kickstand rods for patients with significant coronal deformity or imbalance. Here is even an example of rod fracture at the site of PSO. As you can see, pedicle screw here. PSO was performed at this level, and the rod has fractured here. Satellite rod is using a short not been a long-term study yet, but according to biomechanical studies and abstract, there has been a substantial reduction of rod fracture rate, and at the site of PSO down to 5% from 1/4%. Here's an example of kickstand rod. Basically, what you do is put in a iliac bolt, an extra iliac bolt, and putting a rod at the level of, at the side of convexity to kickstand and prevent the, to prevent the fatigue fracture from arising from the excessive coronal deformity. And so far at 2-year follow-up, there was no kickstand construct failure or worsening of coronal imbalance after surgery. So PJK, or proximal junctional kyphosis, and proximal junctional failure is another big topic in deformity, and that's because this is something that we see over and over again in deformity surgery. Right after the surgery, patients are doing well. They maintain a good sagittal balance, but as time goes on, you went from 2 centimeters to 5 centimeters, and look at the angle of upper instrumental vertebrae, UIV and UIV, UIV plus 2, is that you become more kyphotic at that angle. And what was supposed to be a short segment fusion becomes T10 to pelvis and T4 to pelvis. In this case, this is a 69-year-old female. This patient was fairly well balanced sagittally, had a pelvic incident, lumbar lordosis, difference of 11 degrees. And after post-op, this patient has that lumbar lordosis pelvic incidence difference of minus 17 degrees. So it's clearly that this patient was overcorrected, hence the adjacent segment disease up here and compression fracture above. And spine surgeons are recognizing the problems of overcorrection, and now we have this age-adjusted alignment goals to reduce PJK. For example, a PI-LL parameter, as I said earlier, should be somewhere between -10 to 10. But in geriatric population, this maybe should be 17, and SVA positive 8 or 80 millimeters or 8 centimeters, because like I said earlier, our tendency as we age is we kyphose forward, and that's where we want to be. This is another paper, I think one of the most important paper that came out in 2019 to reduce PJK and PJF by employing prophylactic implants during surgery to prevent PJKs. On the left is image radiograph without any implants, and this is an radiograph, an example of a PJK and a PJF. Here is one of the 3 implants that they looked into, is to put in a cement at upper instrumental vertebrae, UIV, and UIV plus 1 to reduce this compression fracture above. Another method they looked at was to put a hook at UIV plus 1. And another method was what they call a tethering. You cannot see anything on the radiograph, but what the surgeons did was to drill a spinal laminal junction at UIV plus 1 and UIV plus 2 and put a polyethylene suture and anchoring it to the top of their construct. They had 625 patients, and the incidence overall, including whether they had cements or hooks or tether versus none, was 13%. without any of these prophylactic measures, incidence was 20%, similar to more of a historical frequency for PJK and PJF. Interestingly, they also looked at the age-adjusted parameters, and if these patients were overcorrected, the incidence of PJK was almost 0.25%, and 11% underwent revision surgery. With implants, that percentage went down to 10%, and 6% was revised. But if you combine the adjusted parameters, plus if you employed these three, one of these three implants, then that rate went down even further to 9.9%, and also reduced revision rate down to 4.9%. Looking at other complication rates, infection, I think overall surgeons are doing a better job screening the patients and optimizing patients for these heavily invested surgery. For example, diabetes control, decolonizing, and also there is not a strong evidence, but liberalizing vancomycin powders and IV vancomycin for these big surgeries has shown to reduce the wound infection. When it comes to operative blood loss, surgeons are using TXA and also cell savers to overcome these complications. So far, I've stressed on sagittal imbalance, and how about coronal balance? Evidence of correcting coronal imbalance and resulting in patients doing better is quite weak in the literature. However, if you don't recognize the degree of coronal imbalance prior to surgeries, that can lead to implant failures, and you can actually make the coronal balance even worse after the surgery. And this paper points out exactly that and stresses the importance of fractional curve. What they did was identify 65 patients with degenerative scoliosis, and they grouped these patients into three types of coronal imbalance. A is balance, B is imbalance, and you have the plumb line shifting to concave side. And type C is imbalance, patients with shift to the convex side. And type C, and because of, you have kind of two different curves because of that fractional curve, these patients were at significant risk for surgeons not being able to achieve the coronal correction. And the paper claims that these patients had less improvement in quality of life, although they had a sagittal alignment, a satisfactory sagittal alignment after the surgery. So if you can imagine, if you do a wedge osteotomy at the apex of the curve on type B patients, this patient will become more aligned, right? If you do a wedge osteotomy here. However, if you did a wedge osteotomy here, what you will have is worsening of the coronal imbalance and have that kind of a takeoff phenomenon. So this paper tells us kind of an algorithm to prevent the problems, and meanwhile correcting that coronal imbalance before going into surgery. And what this algorithm tells you is that you want to do a TLIF, a release at the fractional curve on the bottom to give the foundation, and then doing a wedge osteotomy at the apex of the curve to better align after the surgery while achieving the sagittal correction. So these patients, compared to maybe 12 years ago, or maybe 20 years ago, are doing better. When you look at, this is a paper came out in 2021 They looked at 100 non-op versus 180 patients at 5 years. And a patient who underwent surgery had greater improvement in ODI. And a patient in co-op who had complications, serious adverse events, still had a significant improvement in non-op cohort. So what's next in deformity surgery, I think, is predictive analytics is becoming bigger. And I think will help us identify surgeons who will do better on these heavily invested surgeries. I do think that MIS deformity surgeries are gaining more attention. MIS surgery is really maximizing the lateral inner bodies, followed by percutaneous fixation. And here is an example of that. You see just inner bodies alone can correct this severe coronal deformities quite a bit. And of course, you'd follow this with percutaneous fixation. So here is kind of a deformity algorithm for MIS deformity surgery. Basically, you would group your patient into 3 types of deformity classes. Class 1 and Class 2 with relatively minor deformity. They can undergo MIS type of surgery, lateral or anterior ALIF, inner body followed by percutaneous fixation. Whereas Class C, these type of deformity will now require osteotomies. So in summary, pelvic parameters describe position of the pelvis by measuring the sacrum and femoral head. This determines where lumbar lordosis should be, providing alignment objective. Pelvic tilt is measurement of a compensatory mechanism. For trainees, remember this numbers, 5 centimeters, 10 degrees, and 20 degrees, because these pelvic parameters have started appearing in written board exams. And everybody should practice with SurgeMap, and trainees here should have access to it. With extensive research in ASD, major complication rates are improving, and we have proof that these patients are doing better. And as seen in this graph here, 2015, about time where I started training, there has been just, the study of looking at improving the outcome of this deformity surgery has really taken off. And finally, recognizing fractional curve when instrumenting down to the sacrum is very important, and especially in patients with coronal imbalance. Thank you very much.